Hi and welcome to week 6 of 8 Beats to Better Outcomes, and sorry for the 6-month delay. We are now planning to launch our new intrapartum guidance in the middle of January, so we've got a couple of the 8 Beats left to do. This week is all about the second stage and the changes in the new NICE guidance that will be in our local guidance that better support us to safely manage the second stage. So why are we talking about the second stage? Well, our management of the second stage of labour in relation to fetal monitoring has changed over the years. Once upon a time, normal for second stage would be common documentation and a reflection of the expectation that CT monitoring would deteriorate in the second stage, with loss of contact, worsening decelerations and changes in baseline and variability, not prompting immediate action. However, we know that interpretation of CTGs in the second stage is much more challenging and that babies are more likely to decompensate and do this at a quicker rate due to the increased interruption to gaseous exchange at the placenta that active pushing brings. So although classifications of first and second stage CTGs remain the same, there are extra considerations that we must consider in the second stage. So what is NICE saying? Well, because of the potential for rapidly evolving hypoxia and the increased chance of loss of contact on the CTG, NICE now states that we should have a lower threshold for seeking a second opinion or assistance in the second stage of labour. To ensure the fetal heart is being monitored consistently, we must check maternal pulse to differentiate between mum and baby at least every 5 minutes and consider using FSE monitoring if there are concerns about being unable to differentiate or if there's lots of loss of contact. Attaching an FSE in the second stage may feel like a bigger intervention than in the first stage, but without good quality monitoring, correct management cannot be determined. Further to this, if accelerations are seen in the second stage, particularly with contractions, this is highly unlikely to be an accurate recording of the baby and is much more likely to be a recording of maternal pulse rising in response to pain. Do not take accelerations as reassurance that the baby is coping, and instead consider FSE or expediting birth if accurate monitoring is not possible. The guidance also now prompts us to consider signs of hypoxia in the second stage and how these may present. When decelerations are seen in the second stage, we must also look at any changes to the baseline and variability. Although this is the same in the first stage of labour, a rise in the baseline of more than 20 beats per minute in the second stage becomes a red feature and therefore makes the CTG pathological overall. This is to flag up that hypoxia is more rapidly evolving and the need for quicker intervention in the second stage of labour. Although these changes are more clearly outlined in the new guidance, they may already be part of normal practice for many and feel fairly obvious. The aim of the guidance change is to better support these practices. One part of the new guideline that we may not feel as familiar with, however, is the guidance to discourage active pushing and stop oxytocin in the second stage of labour where there are CTG concerns and birth isn't imminent. This may feel counterproductive, as when a baby is in distress in the second stage, there is an urgency to deliver and to push harder to achieve this. However, by discouraging pushing, this may give the baby a chance to recover and time to make a plan for how and when birth is to be achieved in the safest way possible. And that's it for week 6. No big changes to current practice, but hopefully a guideline that better supports us to escalate concerns and make safe plans for our women and babies. I just want to take this opportunity to wish everyone a happy Christmas and to thank you all for everything you do for not only our women and families, but also for each other as a team. Happy Christmas.